Assalamu alaikum. This is the second part of the acid-base disturbances and EBG interpretation. And now we will talk about the metabolic disorders. The metabolic disorders, it's either metabolic alkalosis or metabolic acidosis. We'll start with the metabolic alkalosis. Metabolic alkalosis diagnosed when there is pH more than 7.4 and the abnormal pH range is above 7.45, but for the sake of EBG interpretation, we will consider metabolic alkalosis if the pH is more than 7.4 and the HCO3 is more than 24. Okay, and here what is the cause of metabolic alkalosis? What do you think? It's either there is increase in the HCO3, the bicarb, or there is loss of the hydrogen ion, the acids. And usually the respiratory system will compensate by hypoventilation to increase the carbon dioxide. Usually metabolic alkalosis is divided or classified to either saline responsive or non-responsive. This to facilitate and help in the management. To differentiate, usually we are using spot urinary chloride can be checked. If the urine chloride is more than 20 milli equivalent, so this is saline unresponsive. If it is less than 20 milli equivalent, it is saline responsive. Okay? So these are the steps. There is metabolic alkalosis in the patient and we cannot identify the cause. If we can identify the cause, and so we will deal with it. If we cannot, we will use the urinary chloride to differentiate and to know the cause of the metabolic alkalosis. So as I told you, now we will do the urine chloride. If urine chloride is less than 20 millimole per liter, this is chloride responsive, and here the causes are usually chloride depletion, as occurring in vomiting, losing of HCl from vomiting, or nasogastric suction, also the same, or chloride diarrhea, okay, or in cases of cystic fibrosis in the lung, or also after diuretic use, long time after diuretic use. Yani we stop diuretics, still we have metabolic alkalosis, and this is different. The chloride depletion, the mechanism of alkalosis here is different than that one which occur while we are using the diuretics. Okay, if the urine chloride is more than 20 millimole, this is chloride resistance. And here, this occurs with the current diuretic use or in severe potassium depletion or in exogenous alkali, like these people taking antacids all the time. Also occur with magnesium deficiency. Okay, so in case of alkalosis, usually we are checking for other electrolytes. Hypokalemia may be a cause, hypomagnesemia may be a cause, excess calcium may be a cause. We will check also for the blood pressure of the patient. If the blood pressure of the patient is elevated, this may be hyperaldosteronism. Okay, if it is the blood pressure is low, there is no hypertension, this may be congenital syndrome, Bartter syndrome, or Gentleman syndrome. And this, as I will tell you, they are working in this syndrome. There is lesion like that one if we are using diuretics. The Bartter syndrome like that one of loop diuretics, and the Gentleman like the thiazide diuretics. This to simplify only and to remind you by the causes again. Addition of bicarbonate, as we said, if there is bicarbonate added, and these causes either lactated ringer or blood transfusion or total parenteral nutrition, will only be a cause of metabolic alkalosis if there is abnormal condition. Yani lactated ringer, if giving massive amount, very big amount in short time, can induce metabolic alkalosis. Also blood transfusion, if we are giving a very fast massive blood transfusion, the citrate in the blood metabolized by healthy liver, it will cause metabolic alkalosis. Total parenteral nutrition, if there is error in the calculation of relation between salts and chloride, this also may cause the metabolic alkalosis. But usually this, we never see it in medical, in clinical practice, usually or significant effect of them to cause metabolic alkalosis. Okay. Number 2 is the contraction alkalosis, and here there is loss of bicarbonate pore fluid. There is loss in the fluid of the body, either it is urine, and this urine is free of HCO3, so the amount of HCO3 is increased. Here this is the amount of fluid, and here we lose this fluid, clear fluid, without losing the HCO3, so the amount of HCO3 increased. This what's happened in the vomiting. There is two mechanisms for in vomiting to induce metabolic alkalosis, either by losing hydrogen ion or by losing fluid pore in HCO3. Also same with nasogastric suctioning and with diuretic. There is another mechanism for the diuretic. Also loss of hydrogen ion. Loss of hydrogen ion through the GI or through intracellular shift, as is the case in hypokalemia or in feeding after prolonged fast. In hypokalemia, what occurs is the potassium will move because there is hypokalemia and there is reduction in the serum concentration of potassium. And potassium, as you know, is intracellular component. It will move from the intracellular to the extracellular, and to maintain electron neutrality, hydrogen ion will move from the extracellular to the intracellular, so that we will have alkalosis. Loss of hydrogen ion also can occur through the kidney. So first of all, extrarenal or renal. Through the kidney, through the diuretic, as we said, diuretic can cause can cause metabolic alkalosis by two causes: either losing fluid pore in HCO3, or by the diuretic. They will inhibit the reabsorption of sodium in the tubules of the kidney. Here, either loop diuretic or thiazide diuretic, they are inhibiting here this protein, and here this protein in case of thiazide diuretic. What they are doing, they are inhibiting this protein. So the amount of sodium excreted here and coming to the urine will be more, will be enormous. And in this area, before the urine will be excreted, also electron neutrality should be maintained. And here in this area, the sodium will, there will be trial to absorb the sodium and excrete hydrogen ion in to maintain electron neutrality. There will be trial to absorb sodium to maintain the sodium in the body, and hydrogen ion will be excreted instead of it to maintain electron neutrality of the urine. Also, mineralocorticoids are working by same mechanism. I will tell you now. Mineralocorticoids, how they are working. Here the aldosterone, all of them, aldosterone or angiotensin, have the same effect on sodium. They are doing sodium and salt and water reabsorption. Angiotensin 2 will increase the reabsorption of HCO3. So increasing the amount of HCO3 in the body will cause metabolic alkalosis, while aldosterone will increase the excretion of hydrogen ion, and this also causes metabolic alkalosis. So both aldosterone and angiotensin, they are causing metabolic alkalosis, but by different mechanisms. Okay, another cause which we are seeing in COPD patient usually, this is the post-hypercapnic metabolic alkalosis. What's happening there in this situation? This patient, before putting on mechanical ventilation, is used to have carbon dioxide in high amount. Now there is indication to put him on mechanical ventilation. Okay, what is this indication? Usually disturbed conscious level or presence of acidosis. Okay, but this patient used to have high carbon dioxide, as I said. The body usually compensates by increasing the HCO3. Now we will put the patient on mechanical ventilation to help or to solve the problem of the respiratory acidosis or of the hypoxemia or of the disturbed conscious level. We will increase the wash of carbon dioxide. We will help the patient. When we help the patient, carbon dioxide will go down and the pH will go up, and still will go up because carbon dioxide went down. The HCO3, the kidney compensation, need time to again adjust itself to the normal, to the new carbon dioxide level which the patient reach by the help of the mechanical ventilation. This is a iatrogenic problem, and usually it will delay the weaning of the patient. So that in this situation, when we are putting COPD patient on mechanical ventilation, we should decide the target carbon dioxide which we want to reach to it. We should not normalize the carbon dioxide at all in COPD patient. We will check which pH, which EBG with the pH is about 7.35 at this patient, old pH or old EBG of the patient. This EBG with the pH about 7.35 to 7.39, here this range, the HCO3 or the carbon dioxide is the target carbon dioxide which we want to reach. We should not decrease carbon dioxide less than this. Otherwise, we can use the acetazolamide to correct this problem. And there is a study done, and there is no difference, or using acetazolamide in this condition will help the patient and will not cause any side effects, and also it will not hasten or increase, or increase the time for weaning or decrease the time of mechanical ventilation. Just will help to correct the pH. So we will use the acetazolamide. We will use it if the pH went above the 7.5. We will use it to protect the patient from the bad effects of metabolic alkalosis. What is the treatment of metabolic alkalosis? The treatment will depend upon if it is saline responsive alkalosis or it is saline resistant alkalosis. In saline responsive alkalosis, first of all, causal. We will check if there is the patient is having any cause which induce this metabolic alkalosis. We will treat it. We can give the patient dehydration. Is the most common cause, of course, for the metabolic alkalosis. If there is dehydration, we will give the patient sodium chloride IV. We can use also carbonic anhydrase inhibitors, as I told you now. Treatment of saline unresponsive alkalosis. The causes usually is primary hyperaldosteronism or exogenous steroids. We will check also the cause. If it is hypokalemia or hypomagnesemia, we will treat it. If it is due to inappropriate preparation of the TBN, we will correct it also. If it is due to hypercalcemia or secondary to hypoparathyroidism, we will check for it. The treatment usually causal, correct the electrolyte disturbance, and lastly we can give spironolactone as aldosterone antagonist. How we will differentiate between the two, as I told you, by urine chloride. Now we will jump to the metabolic acidosis. Metabolic acidosis will happen by two ways. Either we are adding acids to the blood, or we are removing the bicarb from the blood. Adding acids, any acid is represented by the free hydrogen ion. Free hydrogen ion, it is representation of any acid. It's not just hydrogen ion, no, just any acid will dissociate and give us the hydrogen ion, which we are concentrating on it, and this is the most important component we are talking about it. Okay, so there is either addition of acids, addition of hydrogen ion, and acids like ethanol, methanol, lactic acid, uremic acid, anything, any acids, salicylate or anything, or it is removal of HCO3. And from here we will divide the acidosis to two parts. The first one, where is HCO3 is lost here. Usually this loss of HCO3 takes time, and during that time the body compensates by increasing the chloride, because the body strives also to maintain electroneutrality. Okay, this is the concept of the anion gap. Here this is the normal situation where the chloride and HCO3 and unmeasured anion. In this situation there is loss of HCO3, and this takes time so that the body have enough time to increase the reabsorption of chloride from the kidney, from the urine. This is the situation of HCO3 loss. In case of hydrogen ion excess, what will happen? The hydrogen ion will come take the HCO3, okay, very rapidly. The HCO3 will be consumed, and there is no time for the chloride to increase. And this is the second type of the acidosis, metabolic acidosis. So here this is normal. Here the anion gap, we will consider the unmeasured anion as the anion gap. Here the unmeasured anion will not be changed. Here also the anion gap, the unmeasured anion is the anion gap, will not be changed, but this will be called hyperchloremic metabolic acidosis. Here when the hydrogen ion is added, the unmeasured anion is increased, and here this will be called normal chloremic or high anion gap metabolic acidosis. Okay. Again, electroneutrality should be maintained in the body. The body have cations represented by the potassium and sodium, and unmeasured cation like magnesium, calcium, and all the positively charged electrolytes. And then we have also the negative component, and this negative component composed of the HCO3 and chloride mainly, and unmeasured anion. Most of this unmeasured anion is albumin. Most of it, we can say 90% of the unmeasured anion is albumin. Okay, or other protein or sulfate or anything I will now tell you. And here normally the anion is more than the cation. Okay, because we are usually counting only measuring the or calculating the sodium. This is the amount of the anion gap. This normally present. What happened in normal anion gap metabolic acidosis? As I told you, there is slow loss of HCO3, and the chloride will have the time to increase. Okay, so that the anion gap will be kept normal. In case of elevated anion gap metabolic acidosis, the acids added to the blood consuming the HCO3, the chloride don't have time to be to increase. The body did not have time to increase the chloride amount, so that the anion gap will increase. What are the causes of normal anion gap acidosis? It occurs if there is loss, as I told you, of HCO3 through the GI or through the kidney. Okay, and the body will compensate by increase in chloride, and the anion gap will not be changed. Also, if there is exogenous chloride administration, the HCO3 will fall, but the anion gap will not change. So the causes: GIT loss of bicarb like in diarrhea, like in pancreatic or biliary drainage, in urinary diversion, and the renal loss of bicarb, usually compensation for respiratory alkalosis. Okay, and then renal in case of renal tubular acidosis, and in renal hypoperfusion. In renal hypoperfusion, what will happen in renal hypoperfusion? The renin and the aldosterone will work to increase the blood volume. Okay. Also, in case of carbonic anhydrase inhibitor, acetazolamide will cause also normal anion gap acidosis because it increases the renal loss of bicarb. Other causes is HCl or ammonium chloride infusion or chloride gas inhalation. This one, the gas which used in wars. GIT loss of bicarb, again representation, diarrhea, fistula or drains. Okay, and renal loss of bicarb as in renal tubular acidosis or hypoaldosteronism. Now we will talk about the high anion gap acidosis. The causes, all of us know it, mud piles. Okay, lactic acidosis, ketoacidosis, diabetic or alcoholic ketoacidosis, also alcohol poison or drug intoxication, and renal failure in the late stage. Again, this is the concept of the anion gap. I wanted to be clear in your mind. We said it is artificial difference between the commonly measured anion and cations, but actually in the body there is no any difference, and electroneutrality should be maintained all the time. The cations, sodium, potassium, calcium, magnesium. The anion, the HCO3, the chloride, the protein, this is the most important one, and organic acids, phosphate and sulfate. Anion gap is calculated by sodium minus chloride plus HCO3. Usually it equals to 12 millimole per liter. Don't forget about the adjusted anion gap. As I told you, albumin is the most important component in the anion gap. It means it forms 11 millimole per liter of the anion gap. It is 12, it is 11 millimole per liter of the anion gap made up by albumin, so that we should not neglect it. And if the patient having hypoalbuminemia, and having high anion gap, we should correct the anion gap, adjusted anion gap. After we calculate the anion gap in patient with hypoalbuminemia, we should do something or correct the anion gap by adjusted anion gap. It is the observed anion gap. Now I measured the anion gap of the patient. I calculated it is, for example, it is 14. The albumin of the patient is 2. So that's what I will do. The normal albumin is 4 minus 2, the observed albumin. I will multiply it in 0.25. Okay, if the albumin here represented in concentration per liter, if the albumin represented in the concentration gram per deciliter, so the factor will be 2.5. This is the adjusted anion gap. Now another concept, very important to know it, and it is very easy. Just know one way to represent it, and don't bother yourself by the multiple equations, because all of them are having the same idea. What is the idea behind the delta gap? The delta gap, want to say that the change in the anion gap equal the change in the HCO3. If this is the case, the change in the delta gap equal the change in the HCO3, so we have only one type of disturbance, which is the anion gap metabolic acidosis, the high anion gap metabolic acidosis. Okay, so the delta anion gap usually calculated by the patient anion gap minus patient anion gap minus the normal anion gap, which is 12 milliequivalent per liter, okay, minus the delta HCO3. Delta HCO3 is 24, which is the normal HCO3 minus the patient HCO3. If it is 0, so there is no difference between the delta anion gap and the delta HCO3, so there is only anion gap acidosis. Okay, so delta gap equal delta anion gap minus delta HCO3. A positive delta gap of more than 6 milliequivalent per liter is suggestive of the presence of metabolic alkalosis. Okay, or suggestive to the presence of HCO3 retention. Okay, how this come? This means that the HCO3 is not, there is addition of HCO3. There is metabolic alkalosis due to addition of acids, but still there is additionally HCO3 present. Okay, so that there is associated metabolic alkalosis. Okay, the delta gap of less than 6 is suggestive of presence of hyperchloremic acidosis or HCO3 excretion. And also the number 6, it's here written in some reference. In other references they are telling it is just 0. Now let's discuss the corrected bicarbonate. Also it is the same idea. Calculated by the HCO3 of the patient plus the change in the anion gap. Now the patient having metabolic acidosis, this means that the HCO3 for him is reduced. Okay, this reduction, if it is just that one consumed by the acids which elevate the anion gap, so the change in anion gap plus the HCO3 should be 24. If it is 24, so the patient have only isolated anion gap acidosis. Okay, this is the corrected bicarb. Delta gap or gap ratio. If there is no HCO3 loss or chloride loss, the deficit in HCO3 should equal the excess of anion gap. Okay, so the ratio between them will be 1. If there is HCO3 loss for another reason, so the deficit in HCO3 will be more than the excess in anion gap. Okay, in this situation, the difference, the ratio between them will be less than 1. If it is less than 1, so there is coexistent normal anion gap metabolic acidosis. If there is chloride loss, the deficit in HCO3 will be less than the excess in the anion gap. And in this situation, the equation will be more than 1. The relation between the anion gap excess divided by the deficit in HCO3 will be more than 1. In this situation, the coexistent is metabolic alkalosis. So the patient in this situation will have high anion gap metabolic acidosis and metabolic alkalosis. Another concept, I need you to know it, this disturbing sometime. This is the base excess. What is the base excess? You know, we can't forget about the base excess, but it will not change too much in your knowledge, but just I want you to know, so you will be confident that you know everything about this analysis paper called EPG. Now the base excess, it is just according to Copenhagen School. It is the number of milliequivalent per liter of base or acid needed to titrate the serum pH back to normal at normal temperature, 37 degrees, and carbon dioxide is 40, thus eliminating the respiratory component. We want to know only the metabolic component which affecting this EPG, which was causing this acid-base disturbance, so that we can forget about why it is the name is base excess. But if we remove the base, we can say only it is the number of milliequivalent per liter of acid needed to titrate serum pH back to normal, to 7.4. It will be too much easier. So it is just the amount of acid needed. Either we need to add it or we need to remove it from the serum to return back the pH to 7.4. It reflects only the metabolic component of any disturbance of acid-base balance. The typical reference range of -2 to +2 milliequivalent per liter. If there is metabolic alkalosis, what we need to do? We need to add some acids to the blood to return the pH back to normal. This is logic. So if we only consider the acid, this will make it logic for us. In metabolic alkalosis, the base excess will be positive because we need to add acid to return the pH to normal. In metabolic acidosis, we need to subtract acid from the blood, from the plasma, to return the pH again to normal, so that it is usually represented in negative side. So in acidosis, it will be more than or minus to more in negativity than -2. In alkalosis, it will be more than 2. Okay, so the base excess normally represented from -2 to +2. In metabolic acidosis, it will be less in negativity than -2 millimole per liter. And according to it, we will divide to the acidosis to mild, moderate, marked, or severe. It is mild metabolic acidosis if the base excess -4 to -6. It's moderate metabolic acidosis if the base excess is -6 to -9. It is marked metabolic acidosis if the base excess -9 to -13. It is severe if it is more in negativity than -13. In metabolic alkalosis, it is more than 2 millimole per liter. It will be severe metabolic alkalosis if it is more than 13. It will be marked if it is 9 to 13. It will be moderate if it is 6 to 9, mild from 4 to 6. The same. Another concept I want you to know it is the osmolar gap. What is this osmolar gap? It is the difference between calculated plasma osmolality and the measured osmolality. What this mean? So the osmolar gap, difference between the measured and the calculated. What is the difference between the measured? The measured is that the osmolar gap, which the osmolarity which is measured in the lab. They are measuring it by another chemical ways. Will measure all things, the osmolarity of all components present in the blood. While they calculated, we can only calculate the evident or the clear things which affect the osmolarity, which are the sodium and the glucose and the urea nitrogen. Normally, the gap is less than 10 milliosmolar per kg water. Okay, it is normally less than 10 milliosmol. If it is raised, then it denotes the presence of unaccounted ions. And here there is something very important. It's medical emergency and requires prompt treatment if we find low pH acidosis with elevated anion gap and greatly elevated osmolar gap more than 20. It's medical emergency. You can save lives. This patient needs to be on dialysis, CRRT if unstable. Okay, so the osmolar gap here, again, the osmolar gap, this is the osmolarity which measured in the lab, okay, determined by freezing point depression, okay, minus that one which we calculate, sodium, plus the BUN divided by 2.8, plus glucose divided by 18, okay, and then we will check the difference. The difference usually less than 10. Okay, if it is more than 10, so there is additional solutes present in the plasma. What are the causes of increased osmolar gap? Ethanol, isopropyl alcohol, methanol, and glycine, glycerol, ethylene glycol. Okay. So this is the table which comparing between the causes of increased anion gap and the causes of increased osmolar gap. Causes of increased anion gap: mud bile, methanol, uremia, diabetic ketoacidosis, barialdehyde, phenformin, and isoniazide, iron, lactic acidosis, ethylene glycol, and salicylates. Causes of increased osmolar gap: methanol, ethylene glycol, ethanol, isopropyl alcohol, and osmotic agents like mannitol. So in case of increased anion gap and increased osmolar gap more than 20, this is medical emergency and need prompt intervention, usually by dialysis. Urinary anion gap, this usually used to diagnose the renal tubular acidosis. Okay, usually electroneutrality should be maintained also in urine, and the urinary anion gap calculated by sodium plus potassium minus chloride. Normally the anion gap for urine anion gap is negative. Non-renal loss of bicarbonate like diarrhea, also the urine anion gap will be negative. It will be positive if there is renal loss of bicarbonate or decreased hydrogen ion excretion in case of renal tubular acidosis. The urinary anion gap helps to differentiate between the GIT and renal causes of hypercholemic metabolic acidosis. Okay, this to be clear also to you, we are measuring sodium plus potassium minus chloride. Okay, by this now we finish all the metabolic disturbances, and we also discuss the anion gap, the osmolar gap, and the delta gap, and the urinary anion gap. So we will start the third part and last part, the steps to interpret the APG. And as I told you, I promise you it will be super easy for you. Thank you very much.